Good evening, everyone. Welcome back to our Life in Motion monthly webinar series. I'm Caitlin, and joining us tonight are Dr. Hauser and Bill Clark. A little about them. Dr. Hauser is a board-certified, fellowship-trained orthopedic surgeon with extensive experience in both the operative and non-operative treatments of spinal disorders. Dr. Hauser has received his medical degree from the University of Tennessee College of Medicine and completed a combined orthopedic and neurosurgery spine fellowship at Duke University, gaining comprehensive exposure to the diverse spinal pathologies. And Bill Clark has attended Mississippi State for his undergraduate degree in biomedical engineering and attended Christian Brothers University for PA school. He has been with OrthoSouth since 2017 and continues to work in the operating room, hospital, and clinic settings alongside Dr. Hauser. Together, they share a passion for patient care, committed to helping individuals regain strength and independence through care tailored uniquely to each patient's needs. This evening, they'll be helping you better understand basic spine anatomy, common conditions, imaging techniques, and treatment terminology. Throughout the webinar, they'll both be asking you some questions. When they do, feel free to drop your answers in the comments. It's totally okay if they're wrong. After a few moments, they'll reveal the correct answer and explain. And as always, feel free to submit your questions as they come up in the comments throughout the webinar. Both Dr. Hauser and Bill will answer them live before we close tonight.
All right, so without further ado, thank you both for being here and being a part of our webinar series. I'll let y'all introduce who's who, and then we will get started.
Okay.
Well, hello.
Hello. Yes, thank you all for joining so that we can go over a lot of common spine terms that can sometimes be very confusing. I'm Spencer Hauser, and this is
Bill.
Yep,
Bill Clark.
Bill Clark. We work together pretty much every day, both in the clinic and doing surgery. And I apologize, we had to reschedule this from last week. We had something come up. We got delayed a little bit longer, but hopefully a good chunk of the folks who were hoping to be here were able to make it. And what we've done today is compile a list of common spine terms that can sometimes be very confusing to people. The world of spine has a lot of terms that can be confusing to even people with a lot of medical training, let alone people who do not have any medical training. So hopefully going through this outline that we have, and we've got some good pictures to go along with it, will help clarify, a lot of questions that people have related to spine. So we'll move on. So we'll start fairly simple. We're going to go over just the general regions of the spine. So if you ever see a spine doctor or a spine surgeon, you'll hear them refer to our cervical spine, which is your neck, and it's outlined in green here on the picture. Your thoracic spine is the middle of your back, essentially between your neck and your lower back, where your rib cage is, and that's outlined in orange there. And then the lumbar spine is in pink, and your sacral spine is down at the very bottom near your tailbone, and that's outlined in blue here. A lot of the problems we treat in the clinic are, we treat the whole spine, but I'd say the most common issues we see are in the cervical spine and lumbar spine, because those are the two areas of your back that have the most movement. Those discs can get worn out in those areas and can cause people pain and other issues. So next slide. That leads us into the vertebral body and the intervertebral discs, which are pictured here. The vertebral body refers to the actual bony anatomy, whereas the intervertebral disc, as you can see here, is the softer part, which allows more movement. So you're able to move your body and your spine because the intervertebral discs allow that movement, whereas the vertebral bodies are made of bone, they're rigid, they in and of themselves do not move at all. But when you stack them on top of each other with discs, you're able to move your neck and spine. Which leads us into a question, very, very straightforward question, but what does a disc primarily act as? I might have just given the answer away a second ago.
Yeah, it looks
But,
like it.
It is essentially a cushion or a shock absorber between the bones that also allows for movement. Without these discs, you would not be able to move your back or spine. Okay. So next, we get into within the intervertebral discs, there are different areas. So it has an outer annulus fibrosus, which is harder, and then there's an inner nucleus pulposus, which is pictured here on the screen. And in my clinic, if anybody watching this has been to see me, I'll often refer to it as a jelly donut. I think Bill does the same in his clinic.
That's right.
That's really the best thing I have been able to come up with to describe what it's like. But jelly donut, hard on the outside, it's got the soft jelly on the inside, and that's very similar to what these discs are. And when you're in there doing surgery on them, that's very much what they look like as well. And the texture of the inner part of the disc is very similar to jelly. So it really is a great analogy for these. And we'll get into some more of that later as we discuss treatment of some of the problems that we treat. But we got slides for that here in a bit. So next slide. So the next term that you will hear thrown out if you're seeing a spine doctor sometimes is called the facet joint, or sometimes you'll just hear the term facet. And there are facet joints throughout your spine, in your cervical spine, thoracic spine, and lumbar spine. At each level of your spine, there are two facet joints. There's one on the left and one on the right. But facet is essentially just a fancy term for joint. And that is where the individual bones that make up your spine come together so that you can move your back. Just like, and a lot of people might be more familiar with the bigger joints in the body, which, joints like the knee or the hip. Most folks know that there is cartilage in those joints, and cartilage is like the shock absorber that allows them to glide and move without pain. When the cartilage of a joint gets worn out, it can cause pain. These facet joints are much smaller than those other joints, the hip or the knee joint or the ankle joint or the shoulder joint. There is cartilage in all of those locations, but they are much larger joints, and there are not as many of those. In the spine, you have multiple joints, and you can get facet joint arthritis, meaning the cartilage is worn out and it can cause pain, or you can get little bone spurs that can come off of your facet joint and cause pain. And sometimes those bone spurs can pinch a nerve that can cause pain that might radiate through your buttock and leg. And I know we talk about that a lot when I see patients in the clinic who are having that type of pain, how it could be a bone spur. Sometimes it's one of the discs that we just went over that's bulging back, and we'll go through some more of that here in a minute. And this leads us to this picture. And this is a model of one of the vertebral bodies in a cross section. So this shows you, and when I say Bill, why don't you show what we're looking at here?
Yeah. So this, let me see a little bit closer here. This essentially what we're looking at is right here. So you've got your lamina, you got your spinal nerves coming off, vertebral body here. So rotate it. This is what you're looking at, just in this form.
And in that view, it's almost like, and this is what I'll tell people in the clinic, it's almost like we cut you in half and we're looking straight through your body. So I'm not going to point, but you can see where the nerves are there, but they are surrounded by bone, and that bone protects your nerves on all sides. There's a big vertebral body in the front, so that big portion is the vertebral body in the front. But then around your nerves, all the way around the back, there is a bony canal, and that forms the spinal canal. And throughout part of that spinal canal is your spinal cord. As you get down into your lower back, your spinal cord has usually ended. However, you've got a bunch of nerve roots that continue down and exit through the little openings in the spine, which I think we'll have a picture of that in a minute. You can kind of see it on this model right here. And then it'll go down your buttocks and legs. And that's a great picture of it right there. So that little opening is where individual nerves will exit your spinal canal so that they can go down your legs and allow you to move your legs, your buttocks and legs, is where you'll feel pain often when one of those nerves is getting pinched. And I think that's a pretty good overview. You can see here, what's the next slide look like? There. Yeah, going back to that one, one more back, I think, to that, yeah. So here you can see that vertebral body in the front, but the lamina is that ring of bone that goes around back, and it's labeled there very nicely. And there are certain surgeries where we will remove part of that bone when you've developed either a bone spur or thickened ligaments in that area that are compressing your nerves. And we'll touch on that more here in a few minutes. But that is an area that can sometimes create problems for folks. And sometimes we will do surgeries to either fully or partially remove that. Okay, and we already went through this. That's where the nerves come out, the intervertebral foramen. And that leads us next to some terms that describe common spinal conditions, which are also very confusing to a lot of people. There are conditions related to, as the slide says here, there are conditions related to the bone, and there are some more for nerves. This is a spinal condition that is very common that we see in the clinic frequently, called the vertebral compression fracture. And as you can see, there's a normal spine on the left side there, and there is a spine with a compression fracture on the right. These often happen after an injury, but they do not have to happen after an injury per se. Sometimes it's something as simple as twisting the wrong way or standing up or moving in an awkward way. Depending on how hard someone's bone is can cause a fracture like this. So, we see a lot of patients that have osteopenia or osteoporosis, which is some degree of weakening of the bone. And it does not take much, and they can develop these vertebral compression fractures. So I'm sticking more to the terms, I guess. But that is a common term that you'll hear, and that is what it is. That's a good illustration of what we're talking about when we talk about a vertebral compression fracture. Usually it affects the bone and not the nerves back behind. It can cause a lot of pain, but it will often heal on its own. You have anything to add, Bill?
No, I agree.
Yeah. How about the next slide? Okay. So this is a picture. It's a good picture of facet arthropathy. So you hear that term, and it's this fancy medical term. All it means is arthritis in the joints of your spine. And it can cause pain in your back. So if you have arthritis in the joints of your spine, in and of itself, that could cause back pain. You can also get bone spurs that overgrow from the facet arthropathy that can sometimes pinch a nerve, like we're seeing here in this picture where that arrow is pointing. You have arthritis in that joint, but it's overgrown and it's actually pinching that nerve. And in a person who has something like that going on in their back, often you will get radiating nerve pain down through your buttocks and or legs, or both. So when you hear the term, or if you do hear the term facet arthropathy, it refers to arthritis of that facet joint. But that can cause isolated back pain or a combination of back pain and a pinched nerve if you have a bone spur that has developed that might be irritating one of those nerves. Okay, and yeah, next. So the next one here, I'll let Bill explain this.
Spondylolisthesis is where it's big word for just saying the bones are shifted. So instead of the bones being perfectly lined up, just one is ever so slightly or drastically kind of move forward, which in turn causes a couple things. The central canal to be less in some people. Also the foramen to be less, which can cause stenosis or pinching of the nerve, that leg pain, essentially nerve pain, back pain.
That's it. Yeah, I agree 100%. So and this is probably one of the most common things that we see in the office day in and day out. that and a disc herniation, which we'll touch on here in a minute as well. But spondylolisthesis is unbelievably common. And, oftentimes it's asymptomatic. There are plenty of folks who have this, don't even know they've got it, and they live their lives with it, and it's okay. But it can be very painful because it's bones shifting around in your back. That movement in and of itself can be very painful. And if there is a nerve that gets caught in the crossfire of that shifting, then it can cause nerve pain. And a lot of people, along with back pain, will have nerve pain related to this. It's a form of spinal instability. And you've got an unstable spine. The bones are shifting in places they're not supposed to shift. And it's a common term that you will hear. A lot of times when I say that term in the office, people look at me with this blank stare like, what did you just say? And it's understandable because it's a mouthful. It takes a long time to figure out, what the heck that is. But that's all that term means. It's a fancy term that means your bones are shifting out of position. And like Bill just said, it can be subtle. I see a lot of folks where it's shifting 1 millimeter, 2 millimeters, which doesn't seem like a lot, but it can be enough to cause a lot of pain. And it can be pretty profound where the bones are almost shifted off of each other, which is much more rare, but it can happen. Usually it's somewhere in between, kind of like this x-ray shows. So this x-ray, if you look at the blue line on the back of the vertebral body right there, you can see that they don't line up in a straight line. If I draw a line down the back of those bones, they should all line up in a straight line, and those two are offset. So that is what we're looking at when we're looking for spondylolisthesis in the office. But that's a big one because it's so common. And then this is scoliosis, also a form of spinal instability. Scoliosis refers to the curvature of the spine, looking at your spine, not from a side view like we were just looking at, but from a front view of the spine. If it's curving like you're seeing in these diagrams here, and these pictures here, that is what the term scoliosis refers to. So there are different types of scoliosis that can affect different parts of your spine or your whole spine. But when you hear the term scoliosis, it's referring to this curvature looking at a front view of your spine. And it's another form of spinal, instability, just like the spondylolisthesis that we looked at a second ago. Okay, so here are some additional conditions related to the nerves. And this is one that comes up a lot too. I get a lot of people in the office that will ask, the difference, because you hear all these terms and it's very confusing. It's confusing again, even for people who are trained medically, who might not deal with this all day, every day. So this goes back to the picture we looked at a bit ago, which you can see here as well, that shows the hard outer part of the disc, or the annulus fibrosus, which is the hard outer part of the jelly donut, and the softer inner core of the disc, which is the jelly part of the jelly donut, okay? A disc bulge is that outer part, the annulus, that is bulging, so it can bulge without a chunk of the inner portion actually squirt out. And that can be painful. It can compress nerves. Beyond a disc bulge, you will frequently hear the next term, which is a disc herniation. So when you hear the term herniated disc, what you're really referring to is that inner portion right there, which is the nucleus. It's called the nucleus pulposus. Again, another fancy medical term. It just means the soft inner portion of the disc that has actually pushed through a weak spot in the outer jelly donut. And that can be very irritating to nerves, both from a mechanical perspective, and it can be chemically irritating to the nerves as well. But when you hear of just a disc bulge, often it's referring to that annular bulge. The outer hard part of the disc is bulged out, but the inner part has not squirted out. And then when you hear of a disc herniation, it's often that inner chunk that has squirt out, kind of like you're seeing here in this picture. And it can be isolated like that. You can also get a piece of the disc that pushes out, and then it can kind of migrate up or down your spine a little bit. So sometimes you'll see them not exactly where they originated, but they'll kind of move a few millimeters or a centimeter or so So they can kind of move around in there a bit. Okay. And another term that you will hear, and this might be the most common term you hear in our office, in any spine health care professional's office, day in and day out, and that's spinal stenosis. And spinal stenosis essentially means that you've got nerves that are getting pinched. That spinal canal, so on the top picture that we're looking at right here, you can see that's labeled healthy. You can see the spinal canal. So the spinal canal is the area right there. It's the open area, and that's where the nerves typically run. When you have spinal stenosis, it is a term that means something is causing that spinal canal to be smaller than it should be. And there are multiple things that can do it. One of the most common things that can do it is an overgrown ligament in your back. So there's a ligament, it's called the ligamentum flavum. It's another fancy term that means it's a ligament, and it can get overgrown. And when that gets overgrown, it can put pressure on your nerves. And that is just, a form of degenerative disease of the spine. But that overgrown ligament, when it puts pressure on those nerves, can cause a lot of pain. And it's often more painful when you're up moving around. Do we have another picture of a foraminal stenosis by chance? So you can get central stenosis, meaning that central spinal canal is stenosis. We were looking at a picture earlier that showed early on in the presentation. I don't know that we have to go back to it, but there are individual openings called the intervertebral foramen where the nerves come out, and they can also be stenotic or have spinal stenosis. And the treatment can be very different depending on where you have spinal stenosis. So if you have symptomatic spinal stenosis in your central spinal canal, sometimes you can do okay with a simple surgery called a laminectomy. It's almost like what I always call it a cleanup job. It's just drilling away some bone and getting some of that ligament off your nerves, but not having to put screws and rods or anything like that in. And then if you have stenosis in other areas, sometimes you have to remove so much bone. Here's a picture of that intervertebral foramen. So when the nerve's getting stuck way out there, or getting pinched way out there, sometimes you have to remove so much bone to decompress the nerve that's when you can wind up having to do a spinal fusion, which I know many of us have heard about. But you can get stenosis, pinching of the nerves in multiple different areas. Next, I think we got so this, again, not going to be very hard after listening to that, but which term means narrowing of the space around the nerves? And I think we know the answer. That's it, stenosis. So that just means narrowing of the space around the nerves, but there can be different types of stenosis in different parts of your spine. And treating them can be a little bit different depending on where that is. Okay? And then degenerative disc disease is another term that refers to the intervertebral discs. They can become quite degenerative as well. They can sometimes become dehydrated and lose their fluid content, and they start to look a lot smaller on the MRI, and sometimes they turn dark on the MRI as compared to the other discs, and that can also cause some degree of back pain, and sometimes can pinch a nerve. If your disc starts out this tall and then eventually shrinks down and down and down, the little openings where the nerves come out can start to get pinched off. These discs here prop the bones open and keep the holes for the nerves open. So if the discs get a lot smaller, sometimes those nerves, the nerve openings get a lot smaller, and the nerve can get pinched because of that as well. So I think let's move on to the next. So this is a good one. This is something that comes up a lot as well. Which imaging test shows nerves and soft tissues the best? Bill, what's your answer?
MRI. That's my guess.
MRI. So Yeah, so we'll go through each of these. So do you
Start. Yeah, you can go ahead.
do you have pictures of x-rays or anything up here?
Yeah, I can pull up the one we were just showing.
Yeah, it's okay. So I'm just going to go through a little bit of this. So we'll start with x-rays. We get x-rays on almost everyone who comes through the office with pain. Sometimes you get really, here's a good x-ray. X-ray shows your bone and your spinal alignment pretty good. So you come in and you get an x-ray, and looking at the x-ray, you can get an overall picture of someone's spinal alignment, if they've got a lot of arthritis in their back, if their bones are shifting out of position. A lot of times I'll have folks, and I know if some of you listening have seen me in the office, I might have gotten an x-ray with you bending around. So I'll get an x-ray with you standing straight up, but then with you bending forwards and backwards. And that can help accentuate any movement going on in the back so that we can see it. Maybe you might not see it very well when you're just standing there, but if you start moving around and all of a sudden you can see the bones shifting, that can clue you in that potentially this problem that's up on the screen right now, spondylolisthesis, could be the culprit that's causing some of your pain. And you can sometimes see other things like soft tissue. I get a lot of people asking me, like the little black, you can see in the top left corner of that x-ray picture, you can see little black bubbles. I get a lot of people that ask what are those, and so that those are gas bubbles in your intestines. You can see that kind of stuff as well. But really, these x-rays show spinal alignment really nicely. They show the bones nicely, and they can give you a good overall picture if you've got some degree of instability going on. They can show you scoliosis as well. And then, do you have a picture of a CT? So CT scan is next. We don't have a picture of it, but a CT scan shows very similar things to an x-ray, but it is much, much, much more detailed. So when we get a CT scan, we're looking at bone, typically. You can see soft tissue as well. However, it is great at showing bone. So we'll often get a CT scan if we have done surgery on someone and we want to make sure the bone has formed the way we want it to. You can see that much better on a CT scan. So I will often get a CT scan if needed months after having done a surgery, to, if there's any question about whether it's fused, we'll get a CT scan to look at that much more closely than even an x-ray can show. And then beyond a CT scan, you get into an MRI. Right. And an MRI shows soft tissue much, much more detailed than in fact, you really can't see soft tissue very well on a CT scan, or you can a little bit on a CT scan, not so much on an x-ray, but an MRI shows it very, very well. It shows the nerves very well. It shows the discs very well. And we will often get that when somebody comes in and we're concerned about nerve compression or stenosis or disc herniation, we'll be able to see that very clearly on an MRI, whereas the other two types of imaging might not show it. We might have a suspicion, and often just listening to somebody talk and the way their pain hurts, when it's hurting, what motion makes it hurt, what movement makes it hurt, you have a pretty good clue what you think is causing it. But to definitively know and to be able to address it with whatever you're going to do, whether that's a nerve block or surgery, you have to get an MRI so that you absolutely know what you're dealing with, where it's located, and the extent of it. Okay. And that brings us into some terminology related to treatment. So we do a lot of these. We send a lot of people to get epidural steroid injections. And there's some confusion related to this as well. So epidural steroid injection is often called a nerve block. And I would say they're essentially interchangeable terms. A lot of people are somewhat confused by that. So a nerve block is what I will often call it in the office. But when I say nerve block, I'm typically referring to an epidural steroid injection. Do you get a lot of confusion related to that?
Yes.
Yeah. So they are basically the same thing, a nerve block and an epidural steroid injection. There are different areas you can put an epidural steroid injection into. You can put it right into that central spinal canal, or you can put it out further where the nerves exit, and that's called a transforaminal epidural steroid injection. Yeah. So this is, I don't know if you can see this.
Sorry. Centrally.
You're putting it right there, And when you have a transforaminal, you're really targeting one specific nerve that you think is inflamed by something, whether that be overgrown tissue or a bone spur, often a disc herniation. But epidural steroid injection is a nerve block, and we will often use those to try to calm down an inflamed nerve. Those are, when you hear about an epidural steroid injection or nerve block, those are targeting typically pain coming from a nerve, which then leads us to facet joint injections. A lot of you have probably heard the term facet joint injections, or there are some other terms which I don't know that we've got listed on here, but there's something called radiofrequency ablation. A lot of the times that is referred to as burning of the nerves. But when you have a facet joint injection, as opposed to an epidural steroid injection, the medicine, it's essentially the same medicine, but the facet joint injection, the medicine is actually going into that joint where you can see the green arrow right there. And that is an attempt to treat pain that is coming from arthritis in your facet joint as opposed to a pinched nerve. So a lot of times when you get a facet joint injection, that's for pain in your back as opposed to pain radiating down through your buttock or legs. So you kind of talk to the patient, figure out where the pain is, and then look at their imaging and put the two together and then come up with the treatment plan based on what you see. Go back one more. Another term, just to the facet joint injection, if you don't mind. Another term that comes up with facet joint injections is medial branch blocks or radiofrequency ablation. And there are, a lot of people will refer to radiofrequency ablation as burning of the nerves. And there's a lot of confusion with regard to that as well in the office, because you can't burn the big nerves that go down your leg. A lot of people think we're going to burn and kill the big long nerves that come out of the spine, these big nerves right here. And these are the nerves that you use to move your foot, move your leg. You cannot burn these nerves. So when we refer to burning of the nerves or radiofrequency ablation, there's a little tiny branch of the nerves that comes off and goes to the facet joint. And if you burn that, then you can no longer feel pain from the facet joint. So that's the nerve that is being referred to with radiofrequency ablation or burning of the nerve, not the big nerves that go down your leg. And often that will be used to treat arthritis in the facet joints as well. So I think it's worth mentioning that too, because I frequently get asked about burning of the nerves or radiofrequency ablation. So this is another treatment. And I mentioned this a little bit ago. This is called a laminectomy. And when you have stenosis from overgrown bone or ligaments in the central spinal canal, often you can just remove some of that bone and ligament and free up the nerve, as you can see here. So on the left side, you can see those nerves are getting pinched pretty severely. On the right side, part of that bone has been removed, and there's a lot more space for those nerves, and they're not getting pinched as severely. So that procedure can often significantly improve a patient's pain. When you do a laminectomy, which was just pictured, you don't remove any of the disc. You're just removing the bone from the back. A very, very common procedure. You want to talk about this one, Bill?
Discectomy.
Yep.
Discectomy is essentially going in, so our jelly donut that herniated out, going in and finding and retrieving that little piece that's putting pressure on the nerve. So I like models. So essentially the disc herniation has come out, and it can be in multiple locations, whether it's off to the side, the center. So the MRI, like we mentioned earlier, MRI helps correlate where exactly this herniation is. And this discectomy is going in, drilling a little bone away, moving over the nerves, finding the disc, and taking off that mechanical pressure to the nerve.
That's right. So when we do a discectomy, not only are we part of a discectomy is doing a laminectomy. So you do a partial laminectomy, but the main goal is to get down there, move those nerves over, and get that little chunk of disc that has scored out and it's pinching that nerve. We get that off that nerve. So as you can see on this picture, I think this is a great picture that really shows what you're doing. You're drilling a small window of bone back in the posterior part, just enough to get in there, move the nerves over, and then get that chunk of disc out. You are not, as you can see on this picture, you are not removing, the term discectomy really implies, or kind of sounds like you're doing a complete discectomy. You're getting rid of all the disc. You are not doing that with a discectomy because you still need disc. You still got to move. You still need a cushion in there. What you're doing with the discectomy is going in, moving the nerves over, and you're freeing, or you're getting that one chunk of disc that has scored out and that's irritating the nerves out of there. And sometimes it's pretty big, sometimes it's small, it's highly variable, but just removing that single chunk, like you can see on that picture, is typically enough to get people feeling much, much better. And often it relieves their nerve pain pretty readily. I mean, right away, if not, within a week or two. So that is probably the single most common surgery that spine surgeons do, because it's a pretty common issue. And I know that most of you listening probably heard that term before. Spinal fusion comes into play typically when you have spinal instability. So this kind of goes back to what we were talking about earlier. Spondylolisthesis, that fancy term that means the bones are shifting around, is a form of spinal instability. Your bones are moving too much, so we have to put an end to all that movement. This is a good picture of someone who had bone shifting and they've had a spinal fusion, and you can see they no longer have spondylolisthesis. Their bones are lined up nicely and they are fused in that position. So once those bones are fused in that position, there's no more movement, and that does a fantastic job of improving pain for most folks who have that. It can be tough to recover early on, but once those bones are fused, there's no more shifting going on, and people tend to do really well when they have that particular problem. Kyphoplasty, so the fractures we were looking at earlier, this is it, can be painful. Often they will heal on their own without any intervention at all. So we'll typically watch it for a period of time, for a few weeks. If the pain is just not getting any better and the patient is hurting enough to want to have this surgery, there's a small surgery called the kyphoplasty that we can make a very small incision and put cement in the bone. And you can see a picture of that here. We stick a very, very small cannula into the bone. We're able to blow up a little balloon to create a cavity, which you can see in that third picture on the bottom. There's a cavity in there. It's essentially a hole in the bone that we then fill. We pump cement through the same cannula. The cement hardens within about 5 minutes and provides stability to that bone. And if the bone is stable and not moving, most people note immediate improvement to some degree, and then it just continues to improve with time. But most folks who have that particular procedure do very, very well. So that's an option for the fracture. So there are different types of surgeries where sometimes we'll just remove bone, sometimes we'll remove bone and disc, sometimes we'll fuse them, sometimes we'll do this cement in the bone. It just depends on what the problem is, how extensive it is, and how bad folks are hurting. Okay, and I think that gets through the list of most of the common terms that we hear about day in and day out. And we're just going to open it up for any questions that you guys may have.
Yeah, so is there a difference between laminectomy and laminotomy?
There is. So a laminectomy, I'll back up a bit. So these procedures are typically done when something is pinching your nerves. Sometimes it's a single little bone spur. It's nothing too extensive. And it doesn't have to be much. It can be a single little bone spur that causes pretty severe pain. So, and it can also be much more extensive than that. A laminectomy is often what you'll do when it's much more extensive and pinching all of the nerves in the spinal canal. A laminotomy is a more limited version of a laminectomy. So it's essentially you drill a hole and maybe get remove pressure from a smaller area. And that can extend into a foraminotomy. So sometimes you have a bone spur that's extending into the intervertebral foramen, and you can drill away enough bone and kind of go out to the side where that nerve opening is and remove bone from that. And that's called a foraminotomy, but it's within the realm of what's called a laminotomy or a foraminotomy. Sometimes you'll hear the term laminoforaminotomy, and that is essentially the same thing. The laminectomy is just a little bit more extensive removal of bone. So And you can do often when you do a laminotomy or a foraminotomy, you'll limit that to one side. So if, say, the left side looks great, but the right side doesn't look great, sometimes you just go in and you do a right-sided laminoforaminotomy, and that's enough. You don't mess with the left side at all because you don't need to. You just stick to the right side. So you're removing less bone, which is ideal. The less bone you remove, the better. But you got to remove enough to get the job done. So sometimes you have to go on both sides, and that's typically a laminectomy.
Right, next question. You talked a little bit when we were talking about imaging, you talked about how you listen to the patients in the exam room, and a lot of the times what they say can lead you, point you into one direction or another with their care. Mr. Larry says, what is the Hoffman test, and what does pass or fail indicate?
Well, Hoffman test is related to, often it's related to, it's an upper motor neuron finding on physical examination. So if you flick somebody's middle finger and their other fingers are kind of flicking like that, it can be a sign that there is a spinal cord issue, often spinal cord compression, often coming from the neck. So I'll often do that to assess for spinal cord compression in the neck. Just because it doesn't always mean there's spinal cord compression in the neck, but it's something that can lead you in that direction. So that is a test related to compression of the upper motor neurons, which is part of your spinal cord.
Perfect. Is the pass where you notice the twitching, or when you, like, what is the difference between pass and fail?
Well, I don't know that it's a pass or fail test. It's more of a present or not present. So if it's present, then, you know, if you're doing it kind of as a screening tool, that might make you want to look a little bit more. So a lot of times people will come in, anybody who has neck pain, usually I'll just flick their fingernails while they're not paying attention. And if all of a sudden their fingers start doing this, then I'll often look into it a little further. Sometimes we'll go ahead and get an MRI scan. Yeah.
All right, next question is from Joseph. Joseph says, how does scoliosis impact stenosis?
Sometimes people with, there are different types of scoliosis, but sometimes people who have scoliosis can sometimes have stenosis because of it. There's spinal instability, there's some shifting going on, and you can get overgrowth that can wind up pinching your nerves from that. Yeah, so the two can go hand in hand. And you can get it in different areas with scoliosis. People who have scoliosis don't always have stenosis. Sometimes it's a curvature without nerve compression, but often there will be some degree of stenosis within a person who has scoliosis.
Are there different techniques for, the next question is there different techniques for a kyphoplasty?
There are. In theory, they are all, kyphoplasty is essentially sticking an instrument into the bone, creating a void, and then filling that void with cement. Some people use a balloon. So some people use a balloon, they blow the balloon up, that creates a void that you can then fill with cement. Some people use a spatula, which is it's essentially a little metal piece that you can twist around to create a void once it's in there, and you can fill that void. Sometimes you can just go from one side, sometimes you can go from both sides, just depends on what you have to do. But yeah, there are definitely different techniques. The end goal is essentially the same, to fill that vertebral body with cement so that it no longer allows the bones to shift around and cause pain.
All right, we have two more questions.
Yeah, sure.
One is, if you've had imaging done and it shows that you have stenosis, but there's no pain in that area, what can you do so it doesn't get worse and cause?
That's a good question, because that's pretty common. A lot of people have stenosis and they don't even know it. And depending on where it is, so if it's in your neck and it's particularly severe, sometimes you'll.
This is the question specifically says L4-5.
L4-5, okay. So for L4-5, stenosis that is asymptomatic, that's great. It's not causing pain. So the only thing you can really do as an individual is to try to stay nice and healthy as far as your core strength. I tell people to try to have some type of exercise plan for their core and to try to implement it into their daily routine. I mean, that can be as simple as walking regularly. You don't have to be doing hour-long workouts at the gym, but I think if you're doing something to try to work on your core, that's the best thing you can do. And then, sometimes I'll tell people to be somewhat mindful. If you know you've got that in the back of your mind when you're about to pick something super heavy up and strain to do it, just make sure that you're doing it in a controlled manner, and then to be mindful with forceful twisting type activities, that type of stuff. And if you're mindful with some of those types of activities and you're working on your core regularly, you're doing everything you can do. And there's, sometimes it's asymptomatic forever, and sometimes it can turn symptomatic, but that's it.
Awesome. All right, we have one more come in, so we'll do these last two ones. The first one is from Cheryl. She says, what can be done for narrowing of the cervical foramina?
There are, so from a surgical perspective, there are probably two main surgeries you can do. One is where you're going from the front, you do an anterior cervical decompression and either fusion or disc replacement. But when you go in from the front of someone's neck, you can often really nicely get to those bone spurs that are narrowing that opening. You can also go in from the back of the neck and do something called like we just talked about, a laminoforaminotomy, or drill away some of the bone that may be pinching the nerve from the back. So you can do those in combination, or just depending on the specific situation, you can pick an approach. A lot of times it's a bone spur that is more easily attainable through the front. So I would say probably more commonly than not, you go through the front. But there are certainly instances where you can go from the back and avoid plate and screws and all that type of thing, hardware.
All right. Is there another option for spine alignment other than a fusion?
Yeah. So does that refer to anything in particular, or?
No, just a pretty generic.
From
what I have right now.
There are just working on your core to build the muscles up that support your back. That's very helpful. Back braces are good. You don't want to wear a back brace all the time. Ideally, you want to build an internal brace by working on your core, and that's very helpful for supporting your spine. A fusion can realign spine in certain instances when there's instability or major scoliosis. There are other motion-preserving things coming out, such as disc replacement. You got to be the right candidate for that type of thing, but a lot of folks can do really well with that as well.
All right, one last one came in. What about sciatic pain? What do you do? Is it different from what you've already mentioned with core?
Well, exercise and all that is great, and it's helpful. It doesn't always fix all the sciatic pain. A lot of times, but I'll often start by recommending that, or at least having that as part of our plan. Figuring out where it's coming from is important. Usually an MRI scan will point you in the right direction. And once you can figure out where it's coming from, I'll often do one of the epidural steroid injections like we talked about earlier to try to calm down sciatic pain. Depends on what is causing it, how well those are going to work. Disc herniations, those do pretty well because often your body will resorb the disc herniation on its own. So a lot of times that is helpful for sciatic pain. Beyond that, you start to get into surgery. And surgery can be, just depending on the specific circumstance, if it's just a little disc herniation, going in and removing the chunk. If the sciatic pain is coming from stenosis, doing a laminectomy or partial laminectomy to free up the bone that's pinching it. If it's coming from the bone shifting around, then sometimes it winds up being a fusion. All of the things we talked about can cause sciatic pain or radiating buttock and leg pain. How you treat it just depends on what specific thing is causing it. So sometimes it's a disc herniation. Sometimes it's stenosis with no disc herniation, just from overgrown bone spurs. Sometimes it's that shifting of the bones that we mentioned a little bit earlier. And depending on which one of those is causing it, that kind of dictates how you treat it.
Awesome. All right, do y'all have any closing remarks before we end?
I don't think so. You got anything, Bill? I just hope that clarifies. So, those are terms, we see patients all day, every day, and those are some of the terms that most commonly seem to be very confusing for people. And like I said earlier, not just patients, but even other physicians who might not do spine day in and day out. So hopefully that is somewhat clarifying, for a lot of you, because it can be quite confusing. I'm sure there are still some degree of questions, and there are a lot of specific instances that can be much more detailed than that. But that's a good general overview, I think, of just some of the more common terms we see. And that's it.
Awesome. Well,
Hope
thank
that was
you.
helpful.
Yeah, thank you both for being here. If you want to make an appointment with Dr. Hauser or Bill or any of our providers, the information on how to make an appointment will be shown in just a moment. But thank you everyone for watching, and join us next month for our next webinar.